All right, so let's go down and interpret our second ABG. Okay, so remember to put the slash. That's the first thing we're going to do. And we're going to look at this pH. What is this pH level? It's 7.55. All right, so that is high. So we're going to put our up arrow. And what does high mean? It means alkalosis. So we've already answered the second portion. Alkalosis. All right, so now let's look at our CO2 level is 33. All right, so that's a little bit low. And what does a low CO2 level represent? It represents not enough carbonic acid, not enough acid, so that is also alkalosis. Now we look at our bicarb, 23. All right, well, that falls within the normal limit. Our bicarb is normal. So what's causing an alkalotic state? The CO2. And CO2 represents what? The respiratory system. So we're looking at respiratory alkalosis. So not too bad, right? I mean, you interpreted that pretty quickly. So let's move on. All right, so our pH level is 7.5. We can see that that's high alkalosis. All right, and remember the second portion of our question. Now our CO2 level is normal, and our bicarb is 33, which is high. So that's too much base, too much buffer. And too much base or buffer is what? Alkalosis. So that is what's causing the alkalotic state in our pH. So, oh, here I am. I already answered the second portion of the question. Pardon me. All right, so we're looking at metabolic alkalosis. So that's your ABG. All right, one more with our cheat sheet here, and then we're going to take the cheat sheet off. So get our slash going. pH level is 7.36. Well, let's see. That's normal. Our CO2 level is 40. Well, oddly enough, that's normal. And our bicarb is 26. And that's normal. So what do we have here? We have a perfect ABG. This patient is being discharged and is going home. All right, so you're calling the volunteer to come pick them up with the wheelchair. All right, so now we're going to try to go by memory. This is how we're learning. We're taking our little cheat sheet away. All right, so our pH level is 7.32. We know normal is 735 to 745, so that is low, which is an acidotic state. So the second half of our question is acidosis. All right, so our CO2 level is 34, which is low. But not enough CO2 is not acidotic. That's actually alkalotic. All right, so a little tricky. Let's keep moving. All right, so bicarb. Bicarb, normal is 22 to 26, and this is low. So this bicarb is low. So not enough bicarb leads to an acidotic state. All right, so both of our values are out of whack here. So now what do we look at? Well, we have to go back and look at the pH. Is it acidotic or alkalotic? It's acidotic. So we have to figure that the bicarb is the culprit here because the bicarb is showing that it's too low, which is acidotic. So whatever the pH is, the value, we're looking for the value that's causing that abnormality. So what you're looking at right here is compensation. All right, so you don't have enough buffer, and that's causing your pH to be acidotic. So what's happening is your body is compensating by probably breathing too much and trying to lower the CO2. And then that's going to, in turn, hopefully, according to the body, compensate a little bit. But now our pH is still abnormal, so we can't say this is compensated. We know this is metabolic down here, metabolic acidosis. We can't say it's compensated, but we can see that the body's trying to compensate. We can see that because the CO2 levels are going down in an effort to try to reduce the acidity of the blood. All right, so you could say that this was partially compensated. All right, but if you were to just say metabolic acidosis, that would be a correct answer as well. All right, so let's move on to the next one. We're going to get our slash over here. So our pH level is 7.58, which we know is high, so that's an alkalotic state. Our CO2 is low. That is also an alkalotic state, not enough CO2, not enough acid. And then our bicarb is 23, which is normal. So the pH is alkalotic, so we know that this is alkalosis, and the problem comes in from the respiratory system. I can't spell. Okay, respiratory alkalosis. So you've interpreted that ABG. Not too bad, right? See, it's not too hard. All right, so what do we have on this one? Your pH is 7.48, which is high. This is an alkalotic state. Our CO2 is 48. Now that's a little bit high and that's acid. So, okay, a little confusion. Let's go on. Your bicarb is 36 and that is high. But a high base, too much base, is an alkalotic state. So what's causing the pH to be alkalotic? Okay, well, obviously, it's got to be the bicarb. It's too much bicarb, making our pH be a little bit alkalotic. So what's happening is the body is just compensating here, all right, by breathing a little less, trying to hold on to some of that CO2 and help normalize that pH. But what we're looking at here is metabolic alkalosis. So partially compensated. It can't be fully compensated unless this works and the pH goes back to a normal level. So if you were looking at this ABG and this pH was instead, 7.4, let's say 7.44, then you'd be looking at compensated. All right, on to, it looks like our last one. All right, so 7.36, that is normal. Your CO2 level is 58. Well, that's pretty high. You know, the high end of normal for a CO2, remember, is 45. So that's an acidic state. All right, and then your bicarb is 37, which is high. Now that's a base. All right, so this is when we get into kind of a challenging ABG. So what do we really think that this is? Well, the one thing that I do in a situation like this is I remember that the respiratory system, the CO2, is much more powerful than bicarb. All right, so more than likely the respiratory is going to be the problem. All right, so what's happening here? Let's look at this pH. What's our normal pH? 735 to 745. So we're only a tiny bit above the low end of normal. So if this pH was 7.34 instead of 0.36, it would be acidotic, right? And we can see our bicarb is, our CO2 is acidotic. And then the base is 37, but we know that base is not as powerful. So I think when we look at this, we're going to have to say that this is respiratory acidosis, but it is compensated. It is compensated because that pH has gone back into the normal level. All right, so remember I said it's easier to really understand ABGs if we kind of think about what it is that's happening to the patient. All right, so let's go back up to our top ABG. We said that this ABG, pH of 7.30, CO2 of 56, was respiratory acidosis. So what kind of patients are going to go into respiratory acidosis. All right, so we talked about, too much sedation. Too much sedation. So maybe we're in the ICU and we have given this patient propofol, fentanyl, Versed. They might be on Precedex, and they're getting a little too much. So that can cause the patient's respiratory, that can affect the respiratory rates. That's one of the reasons why someone who's on propofol, for example, needs to be intubated, because that propofol is going to lower down their normal respirations, and they need to be on that ventilator in order to have the respiration set and keep them at a higher level. That's what keeps them from dying. And if you think about what happened with Michael Jackson, he was given propofol outside of the hospital setting and without his airway being protected, meaning ventilation. That's what happened to him, and that's why he ended up dying. So for your respiratory acidosis patients, you're going to see this if someone's going into respiratory distress, something's happened and they're just simply not breathing off enough CO2, and that CO2 is collecting in their bloodstream. It can also be, like I said, from opiate overdose. The patient maybe has taken too much heroin, too much oxy, and they're not breathing enough, so they're holding on to too much CO2, making their bloodstream acidotic. Or it can be something that we're doing to the patient. We gave them a little too much morphine, so maybe we were just trying to treat the pain, and we ended up giving them, 6 milligrams of morphine, and it was too much. Because if you think about it, for an older lady, even 2 milligrams of morphine can sometimes be too much and cause respiratory depression. That respiratory depression leads to acidosis, and that's what in turn leads to your code blue situation. And why did they go into a code blue? They're a code blue because they went into respiratory acidosis. So that's why we have to really check on patients when we give them morphine or fentanyl for pain. We need to check their respirations an hour later, look to see what their oxygen levels are, because if we can catch a patient before they turn into a code blue situation, then, we've really saved their life. And we don't always know. Patients they can be different. Sometimes 2 milligrams of morphine is not nearly enough, and other times it can be way too much. It's very patient dependent. So that's why each and every time we give a patient pain medicine or go up and down on our sedation, we need to pay attention to what the end result is. Go back and recheck the vital signs, even if it's just the oxygen. If you just look and the patient is awake and talking, their oxygen levels are normal, the respiration rate's normal, that's all you have to do. You don't even have to go further to check their blood pressure. Just looking at that oxygen level that's related to the respiratory system can be enough to know that the patient's tolerating the medications and they're doing well. All right, so respiratory alkalosis. What kind of a patient did we say suffers from respiratory alkalosis? This is somebody that is breathing too much. They have an increased respiration rate. Okay, so this can be somebody maybe that has just been diagnosed with a severe disease. They've just been told they've had cancer. Maybe we're not even talking about a patient. We could be talking about a family member. A family member at the bedside whose, loved one just got diagnosed with a terrible diagnosis. That might put them into a state of anxiety that they start hyperventilating. It can be from a patient that is mechanically ventilated and those settings are too high. And so the simple fix is going to be what? What are we going to do to fix that? We're going to in turn lower the respiration rate on the vent. So maybe, maybe their respiration rate was set at 14. Now we're going to lower it down to 10, maybe even 8. That's going to be something you're going to work out with the RT at the bedside. All right, so, and then the patient that has metabolic alkalosis. So this is the last one we'll talk about. What kind of patients suffer from metabolic alkalosis? I said alkalosis, pardon me, I meant acidosis. So this is going to be an acid other than your CO2. So this is the patients that are going to be your DKA patients, right? DKA because it's ketoacidosis. So this is ketones in the blood, which are too acidic and are going to lower your pH. Or it can be your septic patients, sepsis, which is giving off your lactic acid. So too much lactic acid in the bloodstream is going to, in turn, lower that pH as well. All right, so thank you for listening to my videos. I sure hope that it helps. Remember 2 things about interpreting ABGs. It is a little bit like math, so practice does make it better. Nothing's ever perfect, of course, but you can get much more proficient at interpreting ABGs by practicing. You can go online and Google ABGs, and you will come across websites that will allow you to practice ABGs on those websites. And then also linking what's happening to the patient. If you think about what's happening to the patient as far as respiratory acidosis or alkalosis, not breathing enough, breathing too much, or being in DKA, then that can also help you to better understand all of these numbers. Thank you very much.